Over 200 people have signed up for today's live stream. We are now on air. Please give them a wave and a whoop.
Welcome to those online and those in the room. My name's Penny. I'm the director of the Q Initiative. And in the next 25 minutes, I'm going to give you partying. I'm also going to give you personal stories. I'm going to take you into the depths of my professional self-doubt. I'm going to suggest 3 priorities for how we can increase the impact that we have and practical ways in which Q and Today can help. I'm going to get you talking to each other, I'm going to get us back into the party spirit, and then I'm going to get you on your way by 10:25 for a fabulous day. Ooh. I think it's right that we start in the party mood because we're celebrating 10 years further support for Q, agreed by the Health Foundation and our country partners in Wales, Northern Ireland, Scotland, and from 2020, Ireland. England, who you know have been a funder of ours since the start, they're set to make a decision soon, and Hugh, the National Director of Improvement, who you'll be hearing from later, is really positive about us continuing our work together. Funding will, of course, be subject to all of the governance you would expect of a big initiative, but the intent to continue and to grow Q is clear. I think it's a real vote of confidence in the potential of the work that we're doing together, and it's a good reason to party. But I thought I'd also use the partying analogy because I think it works quite well for where we are now with Q and how it might feel to be part of it. It's 5 years now since Q was co-designed with its founding members. That's a good period of time, but if those last 5 years were a party, there's quite a few people who might feel like they only arrived in the last half hour. There are certainly some who have found their groove. They're getting on down to productive collaboration with people they seem to now have always known. But there'll be other people who might feel like you've only just arrived, maybe you're hanging around the drinks table still, feeling a bit awkward, perhaps checking your phone, still at the small talk stage. The growth of Q is such that we'll always have a lot of relatively new people in the room. Let's have a quick show of hands. How many of you are here for your first Q community event? Great. And how many of you have been a member for a year or less? Fantastic. Okay, so so far as I can call myself host of our collective party, you are all newbies and old hands are very welcome. As host, it's my first job to help break the ice. We're going to keep this simple. Turn to your neighbour and for 90 seconds, share your idea of the perfect party. If you're here on the live stream, I promise we'll be quick. You can dream from your desk. Thank you. Thank you. It's great to hear the energy in the room. Knowing the passion of Q members, I don't think it's too geeky to expect that you're going to keep that energy as we go into the serious business of today. Because I guess this is a party with a serious purpose, and I want to change beat a little now. Imagine that you're wandering with me into that room that's a little bit away from the dance floor, where the mood has turned reflective and people are starting to open up about what matters to them. I want to just share a couple of stories that have been on my mind recently, and why this is relevant to all of us will become clear. I'm proud to have spent my whole career working to make things better in the health service, but I don't know if I'm the only one who sometimes has doubts about whether all of the service changes I introduced always delivered the kind of lasting results they should have done for patients and staff. I had a phone call around 8 weeks ago that stopped me dead, turned that kind of doubt into a profound self-questioning that kind of caught me in the back of my throat and brought tears to my eyes. I was on the phone to the NHS, experiencing the service not as a manager but as a mother, chasing an appointment for my 6-year-old daughter Lois, who'd had some test results that could have suggested a problem in her brain. I think what got to me wasn't that I was being kept on hold for what felt like hours, passed around appointment systems that seemed opaque to everybody involved. It was when I finally got put through to a medical secretary. And she just said, "I can hear you're anxious. I know you just want this sorted out. I'm going to chat to the clinician. I'm going to get you an appointment slot. Here's my direct line if we need to speak again." Now, that kind of kindness and commitment of staff working in the NHS and impossible systems, it comes out time and time again in stories of the NHS. And, I've had good reason to be grateful for it myself over the years. I think what cut deep this time was that it took me back to one of my first jobs in the NHS when, in a bid to improve patient choice while making a better use of resources, I was responsible for centralising admissions and appointments in the hospital I was working in, and in the process taking away the power and, in a few instances, the jobs of medical secretaries like the woman I've been speaking to. And I think I realised in that moment that the work I'd done in the name of improvement might actually have made things worse in terms of giving me the flexibility and personal service that, as a mother, I really needed. And I think, to my shame, it brought home to me how little I'd really understood about the reality of the patient experience of the services that I'd been tasked with changing. The thoughts that occurred to me in that moment and afterwards, I hope might be relevant to anyone in the room who's ever felt that kind of doubt about whether what they're doing is quite good enough. Over the next few days, I thought about how I'd approach that job of redesigning outpatients. I tackled it with all of the enthusiasm of someone just out of university, tasked with some really very good toolkits from the NHS Modernisation Agency. I was really good at throwing at the problem my process mapping, my capacity and demand modelling, and my scheduling skills. I did some role and some facilities redesign, and I did lots of staff engagement. But the work we did to understand the patient and carer experience was pretty superficial. We knew that patients wanted a choice of dates for their appointments, and so we had a clear rationale for our work. But looking back, there wasn't really then the expectation or perhaps the tools that we'd follow through and make sure that the detail of the experience we were designing would meet their needs. My point for today is not that we need to incorporate service user experiences better in improvement work, although it is an area that's far behind where it should be. When I actually attended the packed clinic with my daughter, we turned up at 2 o'clock in the afternoon, and I only got the reassurance I needed from a consultant who was exhausted just before 7 o'clock in the evening. And at that point, I was reminded that if I'd just based my service design around the user experience and what medical secretaries were telling me, then the service solution would have been equally lopsided. My point is that in any improvement project, it's easy to have blind spots, those skills and perspectives that are underdeveloped or absent, and that then become this kind of critical weakness that undermines the impact and the sustainability of what's produced. So, when I think about my priorities for helping us have greater impact, top of the list is something that we've been talking about at the Health Foundation for a little while now. we need to get much better at consistently bringing together all of the skills and perspectives that are needed. Only that way can we be confident that we're designing solutions that are robust enough for the demands that we then place on them. This was, of course, part of why you told us we needed Q in the first place. And I think there's good evidence to back it up, not least Mary Dixon Wood's evaluation of the Safe Clinical Systems programme. There are also practical ways of making this happen. So the work of the Q Lab, for example, or the Big Room methodology that is spreading far and wide through the Flow Coaching Academy. But I think we're still a bit of a way off being able to easily tap into everything we need consistently every time. I've got a reasonably sanguine sense of my own positive impact on the world, and it might seem like this experience affected me a bit harder than it should have done. I suppose, like I'm sure many people in the room, I'm kind of driven by that commitment to making things better, and it hit me hard to think that I might have fallen well short of that. I decided that I'd meet up with a friend. The following weekend we were chatting, and she has a lot of experience with the NHS, so we got talking about this. I think I was looking for reassurance that my experience had perhaps been isolated or in the grand scheme of things wasn't that important. In fact, the conversation led me deeper into discomfort and doubt. And I share this not through some career-limiting public self-flagellation, but because it pushed further my understanding of what I think needs to change. My friend Corinne has a son, Charlie, who's 6 months younger than my daughter, with a set of complex physical health problems, which means that he's currently receiving care from 7 different teams, and for the first 3 years of his life, he was admitted on average once every 6 weeks. Corinne has these 4 lever arch files of all the reports and the notes that she's kept from the appointments that Charlie's had. Corinne has somehow managed to maintain a kind of high-flying career part-time while looking after her son. And I thought, here at last was somebody who would really appreciate the intent of what I'd been doing, giving people a choice of dates so they didn't need to rearrange their lives around them. But she cursed me for it. She described how she often spends 2 hours at a time waiting on the phone to reach hospital call centres to make a booking. And she says if that's what it takes, she'd rather have it sent to her. She described the knowledge that she and other families have built up about which clinics release dates on which time, so she can make sure she's there on the phone, waiting, ready to book an appointment as soon as the lines open. She talks about how the people she speaks to seem disconnected from the teams and the services they're booking into, and how she dreads needing to be transferred and cut off if anything's not clear. This is the daily reality of the NHS in an area that I thought I'd help improve. It set me thinking, how is it that organisations end up delivering a service that is so far from what we'd want for ourselves and for our loved ones? Thinking back to the work I'd done, I think this wasn't just about a shortfall in process design. It was about decisions that were made at the next level of the system, and perhaps a bit of a disconnect between the bottom and the top. I know if I found it difficult to keep the focus on patient experience when I was doing improvement at the front line, when I went on to do roles at organisation and national level, it became harder still to get a full grasp of the implications of my actions. We've introduced really ambitious aspirations for reducing waiting times and did not attend rates in the NHS over the last 2 decades. And at the same time, we've squeezed management and admin budgets, and we've reduced outpatient spend as an area of lower clinical value. These staffing, budget, and incentive choices no doubt have a strong rationale in themselves. But I wonder if we've perhaps combined to create a system blind spot that I think this cartoon captures quite brilliantly. It's a blind spot that might mean that some stats look better, but we've ended up with processes where only those who can afford to take time off during working hours manage to get through, and with others left to be chastised for overusing emergency care. And maybe if we realise it's not working, we're too busy to put it right. Maybe you can tell me with confidence that this isn't happening in your area. I really hope that's so true. But I wonder whether the way we approach improvement is reliably geared to avoiding that risk of a disconnect between our worthy ambitions and the day-to-day reality. And so I want to suggest this as a second priority for improving the way we approach change. I think we need to get beyond debates about whether improvement should be more top-down or bottom-up. Health Foundation work suggests complex change requires action at all levels. We need to find better ways to understand the implications of what we're planning and have the flexibility to change and adjust as we learn. It's not easy, but if we want to be confident that our work is actually addressing the core issues in a way that will last, I think it's our responsibility to help join things up and align as much as it is to sort out whichever we consider to be our bit. It's a bit of a downer. I'm conscious I've chosen to start today with two stories that pose some challenges to me and I think to us as improvers. And I'm conscious this is a difficult message because, in effect, it's calling on us to raise our game, despite, indeed, precisely because this is a time when resources are tight and the pressures on us are high. And I know these priorities are easy to say and harder to do, but then I look around this room and I see the talent and the passion, and I think we owe it to each other to make sure we make the most of it. And I also think doing better in these areas is so clearly within our grasp. There are some really exciting ways in which, through Q, we're making a difference on these fronts. So the Q Lab approach is doing brilliant work, convening people to understand problems and collaboratively develop solutions. We're going to be working with National Voices to co-design with you next year ways to boost the improvement of patients and service users in improvement. And next year, we'll also be designing and launching a new offer, which will be supporting those leading work at a central level to learn from each other and to learn from what we as a community know about how to make improvement work in practice. And today, of course, is a great opportunity for you to tap into perspectives you might feel are less well developed in your work. There are sessions today that could give you resources and insight that might help you with whatever's in the centre of your circle. And people in the room from all levels of the health and care system with a wealth of expertise. Get a little taste of that now by speaking to your neighbour for, say, 2 minutes about something you're working on and some of the perspectives or skills that you might hope to tap into today. Feels invariably long. I'm sorry, that's your 2 minutes up. I promise you'll have plenty of opportunities to talk to each other today. Woo, we can get the lights to take the signals, guys. Plenty of chance to speak later, I promise. Okay, so I've talked so far about how we need to invest time in ensuring we have a rounded understanding of issues and solutions, and how we need to align action at different levels in the system. But I think there's a tension in the world of change when it comes to doing this. Our experience over many years tells us that successful change, it takes time, skills, resources, connections, and that context is critical, meaning that you can't simply take a solution and drop it in a new place. Yet, while we know this as improvers, the incredible demands on the health system means that pressure is mounting on system leaders for change that is bolder, that's faster, that offers bigger savings at scale and pace with less upfront resource. So if we're going to make the case for more consistently investing what's needed to design really robust solutions locally, we really need to find ways for the benefits to more reliably reach further, even if we know that the sort of pilot and push out approach we often reach for isn't going to work. The Health Foundation and others have been working on this agenda for some years now, both building the evidence and developing approaches to scaling that are both ambitious and credible. We see around us some of the seeds and shoots of a much better approach. And I want to use a couple of outpatient examples to explain. So before I joined the Foundation, I had the pleasure of working in Newham in the East End of London with Shanti, a diabetologist and the clinical lead for innovation and research. And I'm pleased to say, speaking at the event today. Her team realised that their outpatient model wasn't working, and they decided to pilot offering appointments over Skype. Because, and I don't think she'd mind me saying this, Shanti didn't really know one end of a computer from another when she started the work. That actually meant her approach focused not on the technology, but on really understanding the needs of the young people they serve, and seeing the outpatient service within a wider set of changes across the local system. And with Shanti having these well-nurtured research networks, they embedded evaluation from the start, including delving deep into the way that the clinician-patient relationship is affected by moving to virtual appointments. Supported by a Health Foundation grant, they were able to take the time to develop and gradually spread their work. After a couple of years, they secured a further grant, and that helped them set up a unit that now supports organisations with addressing all of the commissioning, operational, technical and other issues that we now understand need to be addressed if you're going to make this seemingly simple change to virtual appointments. At the other end of the UK, in a similar territory, last year, you voted to support NHS Near Me in the first round of Q Exchange, introducing virtual appointments to respond to the very different context of a rural and dispersed population in Scotland. NHS Near Me has gone from being a small local project, again supported by a Health Foundation grant, to an idea that has spread to over 31 clinical specialties, with the process manual shared across the UK. Claire, who leads the project, is an inspiration and also in the room today. So what strikes me about these examples is that they're far from that pilot and push out model, which we know isn't really how spread happens. But they are finding ways to build and share learning throughout, knowing that we can't afford either to solve problems anew in each place. So this is our third suggested priority for shifting the way that we learn and improve. We need funding models, supporting infrastructure, and a culture that encourages learning between peers, iteratively understanding with patients and staff what the issues are and how to address them. When we surveyed the Health Foundation award holders over the last 10 years, what was the one thing that they said would have helped implementation most? Not a target or further funding, but more opportunities for learning. When we surveyed you about moving to the ambitions for outpatient reform, over 400 members responded, and you told us too that when it came to moving to virtual appointments, more support and resources for iterative learning and testing and from learning from each other was what you needed. By all means, let's set big targets to make the most of technology and to change models of care. That will help us create the space and support. But it will only deliver if it's backed by strategies for designing and scaling change that actually work. With thousands of members now in every part of health and care, we can help draw together different skills and perspectives and align action at all levels. And this means we can be confident that the resources, the time, and the passion that we invest in improving care will deliver real and sustainable benefits. And we can build in ways to learn and spread as we go, making the most of the thousands of connections that we know are forming between us. Taken together, prioritising action in these 3 areas could pave the way for a profoundly more collaborative approach to learning and improvement. With long-term backing from Q's partners, we as a community are really well placed to lead the way. Q's infrastructure is here to help and here to stay. So Q Lab and Q Exchange provide focused ways for us to demonstrate new approaches to spread. Q's learning and development offer, not least today's event, provide ways to help you tap into the expertise that you might need. And the organic networks that are developing in Q are also a really critical part of the picture, even if the way they lead to change can sometimes be subtler. Over the coming hours and the weeks and months ahead, Q can help you find the people, the ideas and resources that will make it easier for you to make progress on your priorities, whatever's in the centre of your circle. In the process, you'll be demonstrating a new way of operating that we hope in time will gradually shift culture and practice across the system. But to bring us back to the party analogy, you need to turn up and throw yourself into it if you and we are going to get what we need. Q is diverse and relaxed, much more freestyle than strict dress code. But this is a party where you're expected to bring something, your ideas, your examples, your energy. And you'll need to introduce yourself to new people, be willing to try new methodological delicacies. What's more, you'll get more from it if we not only tuck in, but share things around and mix it up as we do. We have a veritable smorgasbord, I knew I'd forget that, of brilliant stuff today. And both in the sessions and in between, plenty of opportunities for you to make new connections with each other. For those of you joining over live stream, you can watch a few of the sessions today, including the closing plenary where we'll be announcing the winners of this year's Q Exchange programme. We'll be sharing. Yeah. If you do that later every time, it's going to take much longer. And we'll be sharing highlights and resources from the session over our live blog and over Twitter, so please do join us as you can. For those in the room, please go straight to your first breakout session now. On your way out, maybe have a chat to somebody, maybe someone you don't know yet, about what you're looking forward to today. Thank you.